And let's talk about prostate cancer in general terms today in the areas that are most compelling for you.
Well, I think the story of PSA screening still is very viable. PSA screening seems to be now viable with PSAs of 2.5. So anything with a PSA over 2.5 is likely to require biopsies, or at least start evaluating. So I think men are more aware of it. There's no longer the fear of it. It's clear that even a low stage prostate cancer can be treated without surgery or radiation, provided the patient is watched carefully. So there's a move away from some of this high intense, high toxicity therapy to more kinder, gentler therapy. The role of radiation, surgery, and hormones is becoming well defined, and we have good risk groups to define. And more importantly, we have some new therapies. The Provenge story is all the rage, and a vaccine or immunotherapy for prostate cancer was unheard of 5 years ago, and now we have a product that patients can get and with minimal side effects. So it's quite remarkable, and that's a good thing.
What about the whole issue of to screen or not to screen men who are on the fence about having their PSA?
Well, I would definitely still argue for it. The advantage, of course, is knowledge is power. If you know what you have, then you can think clearly and rationally. If you're afraid, you will not proceed accordingly. So my bias is tell men, get their PSA screened, get a biopsy, and understand that a Gleason 6 is not a death sentence. A Gleason 7 has to be treated, and if, heaven forbid, you are a Gleason 8, 9, or 10, go after it full bore.
What is happening? I know in Europe, I believe it's called HIFU.
HIFU, yes. Yeah.
And that is using ultrasound?
It's a high-focused ultrasound, and it's no better than radiation or surgery. I mean, so I sort of put it in the other category.
And the reason I ask, though, more and more American men are picking themselves up and running off to Europe, in particular Germany, for treatment. Now, I know there are some trials happening in the U.S. For more advanced disease, but in Europe they're using this technology for early stage disease. Do you see that becoming?
I do see it, but you know what? There is no theoretic advantage over radiation or surgery. It's the same. You're destroying the cancer in the local area. We 10 years ago had all the rage about cryosurgery. Now we have HIFU, but there is no benefit of those two modalities over radiation.
Long-term side effects, no benefit there either. No. The refinement of radiation with IMRT has been fabulous.
It's been very good, and the refinement of surgery with robotics has been wonderful. So patients are getting more therapy, more effective therapy with fewer side effects.
All right, so now that we've seen the advancement with the vaccine, what's on the horizon? Where do you think we're going to be going with this disease?
Well, it's very clear that the second line of therapy is now these new agents that block the androgen receptor. The drugs from Cougar, now J&J, the drugs from Millennium, MDV 3100, there's drugs from Tokai and Takeda. All of these drugs are going to come before, or in some cases after, chemotherapy. They are clearly effective, and we hope that they will be on the market sometime in the next 3 to maybe 12 months. After chemotherapy, we have actually a nice new drug, this new drug called cabazitaxel from Sanofi Aventis, which just was reported this year, and we hope will get FDA approval. Seems to extend life.
Is that a chemotherapeutic
agent? It's a standard chemotherapy drug.
So how far are we from looking at prostate cancer and treating it in a more targeted molecular therapy fashion rather than chemotherapy?
Well, you know what? Chemotherapy continues to deliver and deliver well. Its success has never been compromised. To it, we add these targeted therapies. So
it's a combination.
It's a combination, right. So at this meeting this time, Roberto Pili reported that an anti-angiogenic agent is actually useful. And so there's growing evidence that these targeted agents are useful. How useful and how toxic is going to still be a matter of debate in these older men.
I do have a question about the Provenge.
Yes.
Is that, because it's immunotherapy, is that a drug that any man would be eligible for, or is there a criteria? Do you have to look at a tissue specimen and see if there's some sort of overexpression, I imagine, of a protein? Or?
No, it's very straightforward. Men have to have metastatic cancer. It has to have spread, and they have to preferably not be on chemotherapy or anything that depresses the immune system like corticosteroids. But it seems to work in virtually everyone. There were 3 posters today on Provenge success rates, and they seem to be related to the number of immune cells that are given back to the patient. So it's quite remarkable and seems to be extremely well tolerated.
So the drug really is a huge shift in the way in which we treat prostate cancer.
I think so.
What about family risk now? People always want to know, my brother had prostate cancer, what's my risk?
Well, it continues to be a problem, but there is unfortunately nothing like there is in breast cancer where you can do a BRCA1 or a BRCA2. We don't have that test for prostate cancer, yet we know that 35 to 40% of prostate cancers are genetic.
So yeah, and about the BRCA risk, if one has a BRCA mutation, are they at higher risk for prostate cancer?
They are. In fact, I had a family who had a clear-cut BRCA mutation. One of this fellow's cousins had a BRCA mutation in ovarian cancer. He and 2 or 3 of his brothers, and his insurance wouldn't pay for his BRCA testing.
See, I think this is not only an issue for the advocate community to take on, but far greater education. We have done a disservice in the sense that while most people now have heard of the BRCA mutation, we think of it in terms of breast and ovarian, and we need to look at prostate, we need to look at pancreatic, and today I heard that there's even a possibility that it may affect or have an impact on lung cancer.
Yeah, it may well be. This is, you know, I tell in fact, in my notes to myself and to the referring doctors, I say, this patient likely comes from a BRCA mutation family, and I would encourage testing of the family members if possible. And the answer is that we haven't focused on that. And I tell a guy who's 60, who's got 2 sons in their 30s and 40s, have your son PSA tested. But wouldn't it make more sense to have them BRCA tested, so to speak, if they really have a BRCA mutation?
So you know, it's interesting, with ovarian cancer, you can go in and do something prophylactically.
Right.
I don't know what you would do. There's no intervention to...
Well, you would obviously biopsy earlier, and you would obviously screen more aggressively. And, you know, we all live with risk. So the risk that a man lives with the BRCA mutation is the same as a woman lives with the risk of a BRCA mutation.
So before we close, what are you working on, if you can just hint to it?
Sure. So some of the new stuff is the Provenge earlier in patients, trying to enhance the Provenge vaccine story. The other stories that are developing are the new targeted agents that are seemingly more effective and less toxic. Again, they're anti-angiogenic. We had a sort of a disappointment today that the Avastin added to chemotherapy did not add expected life that we thought we would get. But it nonetheless did move the bar. Avastin did, not enough to be safe or effective, but certainly it moved the bar. So I think some of these newer oral agents will still be useful in prostate cancer. I look forward to continuing this process that I've been at for 30 years.
It's a pleasure to see you, Dr. Vogelzang.
It's great seeing you.